Hi, my name is Kenzie Gilmore. Welcome to my YouTube channel. We are talking about PCOS. This is going to be the second video PCOS series. So if you did not look at the first video, which talks about the etiology, the types, and the definition of PCOS, I feel like that's a really important video to look at because it does lay out the foundation for PCOS. So today we're going to dive right in. We're going to be looking at menstrual cycles, insulin resistance, and how nutrition can help manage the symptoms of PCOS. So let's look at this menstrual cycle overview. So the plasma concentrations of estrogen, progesterone, luteinizing hormone, and follicle stimulating hormone during the human menstrual cycle correspond to the proliferative and the secretory changes in the endometrium. Estrogen is the predominant hormone in the pre-ovulatory phase, which is our follicular phase, and progesterone is the predominant hormone in our post-ovulatory phase, which is our luteal phase. Adequate levels of the follicle-stimulating hormone and luteinizing hormone are necessary for the cycle to proceed in a physiologic manner. Pathophysiology of PCOS is characterized by ovarian enzyme dysregulation, which involves the theca and granulosa cells, which surround the oocyte in the secondary stage of development. And if you remember from my first video, I talked a little bit about theca cells in the ovary. An increased gonadotropin releasing hormone, which that hormone is responsible for the release of the follicle stimulating hormone and luteinizing hormone, which controls when ovulation happens. An increase of that gonadotropin releasing hormone, which may lead to the aberration of the luteinizing hormone secretion. Luteinizing hormone stimulates the theca cells in the ovaries to produce androstenedione and testosterone. Testosterone can then be converted to estradiol in the granulosa cell. Insulin also stimulates the theca cells and inhibits SHBG production, sex hormone binding globulin production. That hormone is actually responsible for the amount of testosterone that can be taken up by tissues in the body. A review of the metabolic pathways for the ovarian biogenesis of estrogen and progesterone indicates that androstenedione can be converted to estrogen and testosterone, both of which can be converted to estradiol. The pathogenesis of various clinical manifestations of PCOS involves an increase in luteinizing hormone and insulin, and a decrease in SHBG, and hyperstimulation of the theca cells by insulin and luteinizing hormone. The ovary has insulin receptors. Insulin stimulates ovarian estrogen and androgen secretion. It is thought that insulin resistance leads to anovulation. And if you remember from my first video, anovulation or irregular menstrual cycles is one of the 3 diagnostic criteria for PCOS. That means we can manipulate insulin resistance to help fight anovulation or irregular menstrual cycles. Thus, if insulin levels are lowered, will lead to a higher sex hormone binding globulin and therefore less circulating androgen levels. PCOS, which can cause a decrease in the sex hormone binding globulin, it can lead to an increase in free testosterone, which is thought to lead to an inhibition follicular maturity, as well as hirsutism, which is the facial hair growth that we talked about in my first video, and an increase in free estradiol levels, which in turn leads to an increase of the LH secretion. If you're wanting to have a conversation with your doctor about what type of tests you need to run, I've got a few here down for you for them to analyze. Luteinizing hormone, so LH, follicle stimulating hormone, FSH, prolactin, thyroid function test, so TSH, T4, and T3, 17-hydroxyprogesterone, free testosterone, total testosterone, DHEA sulfate, progesterone, ALT, SHBG, that hormone which we talk so much about today. We can actually measure it. HbA1c, we want to see how your body is responding to your glucose intake and how your insulin is doing to get those glucose into the correct tissues. OGTT, and chromosome analysis. Ultrasound of the ovaries may reveal a population of follicles which has undergone disordered folliculogenesis and elevated luteinizing hormone and insulin levels. 30% of women with regular cycles between the ages of 25 and 30 have morphological characteristics consistent with polycystic ovaries, and 30% of women with PCOS do not have cystic ovaries. Those 30% of women that do not have the polycystic ovaries, in order to be diagnosed with PCOS, they most likely have irregular menstrual cycles and high androgen levels. PCOS and insulin resistance occur in women of all sizes, and that weight should not be regarded as the determining factor or the only focus in the diagnosis and treatment. This would be considered inappropriate as it may put undue stress on a person who is already at risk of self-consciousness about appearance, lower body satisfaction, tendencies towards social avoidance, and depression. I went through the research and I wanted to tackle the main underlying issue with women who have menstrual dysfunction due to insulin resistance, and are there any specific diets these women could adhere to that would help the insulin resistance. The goal of the diet is not to lose weight. The goal of the diet is to get the insulin resistance under control. That is a very important point I want to make. Intermittent fasting, big buzzword, a lot of people talk about it. Essentially, it is expanding the number of hours you're fasting and shortening the number of hours that you're in a fed state. This allows more insulin sensitivity because insulin is not being spiked several times throughout the day. And that allows your body to appropriately use insulin during the fed state, and it gives the gut a rest during the fasted state. For instance, you could stop eating by 8 o'clock at night and start eating at 12 o'clock the next day. That's a 16-hour fast. So that is a 16-8 ratio. This intermittent fasting appear to reverse features of metabolic syndrome, improved insulin sensitivity, reduce oxidative damage, increase resistance to neuronal damage, reduce cognitive impairment like brain fog, and potential promotion to longevity. The next one is ketogenic diet. I want to be very careful when I talk about the ketogenic diet because it is a huge fad diet right now. And I do want to say, if you do choose to do the ketogenic diet, I do recommend medical supervision, because the ketogenic diet was actually designed for children with epilepsy, and it is now took off as a fad diet for weight loss. But it does have some potential risks, and so that's why I recommend, if you do want to do the ketogenic diet for any reason, I do recommend consulting your doctor first. One of the studies showed over 24 weeks, a ketogenic diet resulted in significant reduction in weight, percent-free testosterone, luteinizing hormone, follicle stimulating hormone ratio, and fasting insulin in women with obesity and PCOS. So remember, not every woman with PCOS is going to have a high BMI. So the ketogenic diet was appropriate for this study, this group of women that had medical supervision, that had obesity, meaning that their BMI was higher than 30, and PCOS. The next one is a low glycemic index diet or low glycemic load diet. This describes the effect of a carbohydrate-containing food on blood glucose concentrations over a 2-hour period following consumption of the food. You're going to see how well your body responded to getting that glucose out of your bloodstream and into the cells. And what does that is insulin. You want insulin sensitivity because you want your body to be sensitive enough to get glucose out of the bloodstream and into the cells and tissues properly. As the glycemic index of food determines the postprandial blood glucose response, the theory is that reduction in dietary glycemic index with the subsequent reduction in the postprandial glucose and insulin should have a positive effect on glucose control. In PCOS patients, low glycemic index diets have been associated with improvements in insulin sensitivity, menstrual regularity, anthropometric measurements, and lipids. Something noteworthy to mention, a 12-week randomized controlled trial showed adherence to low glycemic index, high protein diet caused significant increase in insulin sensitivity and decrease in a high sensitive C-reactive protein level when compared with a conventional diet. And the C-reactive protein level basically measures inflammation in the body. Therefore, a low glycemic index diet may not be ideal for the PCOS population because of the insulinemic effects of some low glycemic foods. The last diet I'm going to talk about is the Mediterranean diet, which consists of fish, monosaturated fats from olive oil, fruits, vegetables, whole grains, legumes, nuts, and moderate alcohol consumption. Certain components of this diet, such as the high consumption of omega-3 fatty acids, improve outcome of PCOS, including reductions in bioavailable androgens, so how much the body allows testosterone and estradiol to be in the bloodstream, triglycerides, blood pressure, glucose, and surrogate markers of insulin resistance. So the Mediterranean diet would be one that would have a positive effect on insulin resistance in PCOS patients. Thank you so much for joining me today and sticking around on this video, which discussed menstrual dysfunction, insulin resistance, specific diets that are key in managing your PCOS and getting that insulin resistance under control. Please make sure you hit that subscribe button so you can review the next 3 videos on this PCOS series to help get your PCOS under control. I hope everyone has a great day. Thank you.